So our next topic is functional endoscopic sinus surgery, also known as FESS. Very common surgery nowadays after introduction of endoscopes. So look out at the picture how this FESS is being performed. So what we use a endoscope. This is a long endoscope with a 4 mm outer diameter of this endoscope. This is the 0-degree endoscope attached with the light source here. This is the light source, and nowadays we also use the camera which is being mounted at this point, so you can directly see the images in the TV. So what we will do, we will use the endoscope attached with the light source and a camera mounted over the top, and we just have a lookout in the TV or the camera or the outer source. So the concept of FESS basically is the removal of tissue from osteomeatal complex. Any sort of sinusitis, any sort of polyp, any sort of hypertrophy of the mucosa. So what we will do, by means of FESS, we will introduce the endoscope into the nose, into the sinus. We will remove the tissue from the osteomeatal complex, and we will further facilitate the drainage, proper drainage of the sinuses, and to facilitate the ventilation of the sinuses while conserving the normal mucosa, while conserving the normal non-obstructing anatomy and the mucous membrane. So what do we mean by functional endoscopic? Functional means we have to preserve the normal mucosa, we have to establish the proper drainage of the sinuses, understanding their drainage pathway, and allowing or facilitating the proper drainage of the sinus, and removing of the complete disease that is obscuring the osteomeatal complex. So look at this picture, we are introducing the endoscope. So this is a light projection from this endoscope, and you can see the internal anatomy of the nose. What are the indication of the FESS? Lots of indication nowadays. Firstly, rhinosinusitis. The chronic rhinosinusitis which is not responding to the medical treatment, we can go for the FESS. Then recurrent episode of acute sinusitis, or other indications, sinonasal polyp. This is sino. So sinonasal polyposis. Then comes the frontal mucocele, ethmoidal mucocele, fungal infection like the non-invasive fungal boil, or invasive fungal rhinosinusitis like the mucormycosis, which has been happened a lot in the patients of this COVID era. So invasive fungal sinusitis, non-invasive fungal sinusitis, and other indication to repair the CSF rhinorrhea. We can use the FESS surgery by means of endoscope. We can repair the CSF leakage site, and also treatment of meningoencephalocele sinus tumor like the tumor of the maxillary sinus, ethmoidal sinus, severe exophthalmos, optic nerve decompression, or nasolacrimal duct obstruction leading to the chronic dacryocystitis. The patient of the chronic dacryocystitis, we can do the endoscopic approach and treat the nasolacrimal duct obstruction. Now these are some of the CT scan pictures showing the pathology of the nose. So this is my inferior turbinate in the nose, which seems to be bulky. This is my maxillary sinus in the CT scan, which seems to be completely obstructed. And normally this is the site of the maxillary sinus ostium. So you can see some of the pathology is completely obscuring the maxillary sinus drainage pathway, leading to maxillary sinusitis. You can see the CT scan. This is the coronal section. Coronal section. Coronal section, you better understand what is the coronal section. Means we are taking the plate like this, cutting the face like this. So this is a coronal section, and the picture showing the complete maxillary sinusitis. Now again, this is a section, this is the sagittal section S for the sagittal, that is cutting like this. So we are getting the CT scan picture where you can see this is a frontal sinus. So there is a mass or there is a pathology which is completely obstructing the frontal recess, infecting the anterior group of ethmoidal cells, This is my sphenoid sinus, this is my posterior ethmoidal cell, this is my anterior ethmoidal cell. So pathology is lying in the frontal recess, anterior group of ethmoidal cell and little bit of the posterior ethmoidal cell. Then comes the middle meatus area. This is another, you can see the C, this is another CT scan where pansinusitis is there. That means complete sinuses are being occluded by means of some pathology. Again, this is a sagittal section. You can see the frontal recess here. You can see the anterior and posterior group of ethmoidal cell. This is the sphenoidal sinus area and this is the maxillary sinus area. So complete sinus, frontal, ethmoidal, maxillary and sphenoid. So all sinuses are involved. This is the sagittal cuts of the CT scan. You can see a polyp here, a big polyp with a severe congestion. So these are some of the CT scan picture with the different pathologies in the sinuses, and these all are having an indication for the functional endoscopic sinus surgery. That's how we perform. We introduce the endoscope with the camera mounted over here and a light source here. And we can see the images in the TV, and we are just operating by means of instruments. What are the steps? Now the first step will be uncinectomy. What we will do? So in the middle meatus, suppose this is my middle meatus. So there lies a 3D structure which is the uncinate process. So firstly we have to remove the uncinate process. It has got two parts, the horizontal part and the vertical part. So we have to remove this uncinate process. That will lead to opening up of the infundibulum, which is known as infundibulotomy. And what we will do, then we can go further looking for the maxillary sinus ostium. So we will do the middle meatal enterostomy. That is the opening of the maxillary sinus into the middle meatus. After doing the middle meatal enterostomy, we will do the removal of the anterior group of ethmoidal cell known as anterior ethmoidectomy. Then what we will do, we will clear up the facial recess. So this is the facial recess, suppose. So we will remove the facial recess, we will drain the facial recess. Then we will do the posterior ethmoidectomy, that is removal of the posterior group of ethmoidal cells. And lastly, we will open up the sphenoid sinus, that is sphenoidectomy. Now try to understand it in a better way. We will introduce our endoscope into the nose by means of the nose. So firstly, we will remove the uncinate process. This is the uncinate process. Look out at this diagram. So firstly, what we will do, we will remove the uncinate process. We will remove this. We will remove this uncinate process, open up the infundibulum and enters into the maxillary sinus. So after removing the uncinate process, opening up the infundibulum, we will then do the middle meatal enterostomy, that is opening up of the antrum, that is the maxillary sinus ostium. After that, what we will do, we will remove the anterior group of ethmoidal cells. So these are anterior group of the ethmoidal cells. We will do the anterior ethmoidectomy. Then after that, what we will do, we will open up this frontal recess and enter into the frontal sinus. So we will open up this frontal recess. After that, we will do the posterior ethmoidectomy. We will remove the posterior group of ethmoidal cell and then we will open up the sphenoid sinus. So in this diagram, you can see we have removed the uncinate process. So we can easily enter into the maxillary sinus. We have removed the anterior group of ethmoidal cell and we have opened up the frontal recess. So that's how we proceed into the FESS, that is functional endoscopic sinus surgery. Now what are the complications post-operative? So firstly, intranasal complication. Firstly is the bleeding, then comes the sinusitis, then comes the olfactory dysfunction. Sometime during the FESS, we may end up damaging the olfactory nerves. So that will lead to olfactory dysfunction, and sometimes synechia may be formed. That is the lateral and the medial wall may get attached with the formation of the new mucosa in between them. So these are the intranasal complication. Then comes the orbital complication. Firstly, the corneal abrasion, diplopia, epiphora or orbital infection. Epiphora, If we suppose we end up damaging the lacrimal system that lies in the lacrimal bone, which is opening into the lateral wall of the nose. So while doing the FESS, we may end up damaging the lacrimal system, leading to epiphora. We may end up damaging the lamina propria, which forms the lateral wall of the nose and the medial wall of the orbit. So if we damage the lamina propria and damage some of the muscles like the lateral rectus muscle or some oblique muscle, so that will lead to diplopia. There may be the corneal abrasion, and sometimes the infection may proceed to the orbit. Now lastly the complication comes intracranial. Firstly the CSF leak. If we damage the cribriform plate, leading to the CSF leak. If we damage the parenchyma of the brain, so that will lead to the parenchymal brain injury and sometimes CNS infection. So these are some of the complications of the FESS. That's all.